Hello, everyone. My name's Andrew Vallely. I work with the PNG Institute of Medical Research and the Kirby Institute at the University of New South Wales in Sydney, Australia. And today I'll be talking about point of care HPV testing and same day treatment for cervical screening, cancer prevention and elimination in the Pacific. I have no disclosures or conflicts of interest to declare. And I'd just like to acknowledge the great many people and organizations whose work I'll be representing today, particularly in Papua New Guinea, and also my colleagues in Vanuatu, provincial and district and national health authorities, and particularly pay tribute to the Papua New Guinea Obstetrics and Gynecology Society, who have always been incredibly supportive of our work in the last 10 years and have worked very closely with us to identify the most appropriate screening algorithms for Papua New Guinea, for women in Papua New Guinea. What we've settled on as a credible and robust algorithm that I'll explain a bit of detail today is a strategy based on point of care testing for HPV and same-day treatment. And this is based on a self-collected specimen, a vaginal specimen that's collected at point of care. It's tested using the GeneXpert molecular platform. And then treatment for those who test HPV positive is by thermal ablation of the entire transformation zone of the cervix using a highly portable and novel device as shown here. What we found in our development and our evaluation of this model is that it's very innovative, it's scalable. We found that the self-collected specimens are equivalent to clinician-collected cervical specimens, both for detection of oncogenic HPV infection, but also, and importantly, of underlying cervical disease. The sensitivity of self-collected specimens, for example, is very high, as is the specificity and the positive and negative predictive value for both cervical precancer and cancer. We've also found that this approach is very, very efficient in terms of clinic throughput and our ability to provide this service within primary healthcare facilities in Papua New Guinea. So, for example, a clinic where we have 3 nursing staff who are staffing the clinic is able to see up to 32 women per day and can screen those women in the morning, a single morning, and provide test results to them that same morning and treat women who require treatment by thermal ablation the same day, typically in the afternoon. So typically what we find is that of the women we would see, only about 12 to 13% would require a pelvic exam and clinical assessment, because that's the proportion that are positive. So if we're seeing 32 women, that equates to about 4 that are positive. Those that test negative can be advised that they need to come back in 5 to 10 years, depending on the algorithm being followed. And we find this is highly acceptable and very, very efficient in terms of optimizing experienced staff time. The staff then are able to focus in the afternoon on providing care, doing the pelvic exam, providing thermal ablation and assessment for those 4 women, that 12 to 13% who are test HPV positive. And we have found in our research that around 90% of those who test positive, we can treat the same day by thermal ablation. And 10% of women we find have a lesion that needs referral and assessment by a gynecologist. So those women are referred. Now, if we compare that to our earlier experience, because again, working with the Papua New Guinea Obstetrics and Gynecology Society and our partners in provincial health authorities and national health authorities in Papua New Guinea, we looked at visual inspection-based methods sometime before we introduced HPV testing, and found really that with a similar kind of clinical workload, so with 3 staff, we really could only screen up to 16 women per day. And one of the great problems with this strategy, for us at least, was that because all women required a pelvic examination and visual inspection with acetic acid by a trained and experienced clinician, we found it very, very time consuming. We found that the acceptability both among staff and of course among the women was very poor, in fact. And also, probably the most importantly in many ways, the clinical performance was very poor. So the sensitivity and specificity of this strategy for detection of underlying disease, in our setting at least, was very poor. 20% of the VIA examinations were classified as indeterminate, so women were asked to come back. And because of the great workload, instead of being able to provide cryotherapy, which at that time we were using instead of thermal ablation for treatment of the cervix, instead of being able to apply cryotherapy the same day as we had intended, we unfortunately needed to set up a dedicated treatment day and ask women to return for treatment on that day. And this, unfortunately, we found was associated with substantial losses to follow-up. With our HPV-based point-of-care test and treat strategy, not only have we found it highly acceptable and found that the clinical performance is excellent, we found it's highly cost-effective compared to earlier Pap test-based programs or visual inspection methods for screening. And we found that mathematical modeling that we've conducted is being led by Karen Canfield's group, and we at the Cancer Council in New South Wales. And this work really importantly has shown that if we are able to screen 70% of age-eligible women, so those aged 30 to 54 years, twice in their lifetime, as per the recent WHO recommendations around cervical cancer elimination, we could reduce cervical cancer incidence and mortality in Papua New Guinea by more than 50%. And that's even in the absence of HPV vaccination. So it could have a very substantial impact. So these findings have been recognized, this model has been recognized as an example of innovation and best practice in the Pacific. And it's led to a number of important developments. So first of all, in late 2019, a meeting was held in Fiji by partners across the Pacific, looking at the utilization of HPV-based testing and HPV-based screening in our setting. And the meeting culminated in a call to action towards the elimination of cervical cancer in the Pacific Islands. And at this point, the WHO had recently started to embrace the elimination agenda, which, as you know, has recently been formally launched in November last year. And we realized at this meeting that this new strategy gave us the opportunity to achieve the 70% coverage targets and also the 90% completion of treatment targets that were integral to the elimination coverage targets and the emerging elimination strategy. There's been a lot of debate about moving away from centralized. So we've tended to do our research in the more centralized provincial level hospitals and health facilities, even though they're primary care facilities, they're still at that level, and to move much more into rural health services and into rural health facilities. So around 40% of all the women that attend our current services at provincial level come from rural areas. But given that 87% of all women at risk in Papua New Guinea and a similar percentage across the Pacific live in rural areas, we really have a drive to get out into rural facilities and into rural communities to be able to offer this same strategy and to ensure high coverage and to ensure equitable coverage and to ensure no woman is left behind as the elimination agenda is introduced and scaled up in the Pacific. And we've been looking at which elements of our strategy could be implemented in different layers, different levels of the health system. So self-collection could be conducted in the community and rural health facilities. HPV testing could be conducted in rural health facilities. Thermal ablation, similarly. And there's lots of discussion at the moment around which elements we could bring to the community. So, for example, a team could go to the community, ask women to self-collect specimens, bring them back to a rural health facility for testing, and then subsequently go back and advise women of their test result, with those that are positive being asked to attend the same facility for subsequent treatment. This is what we hope to test in the future in an upcoming project that we're about to start. And we need to we need to test how can we reach women who live in, for example, this setting here this is a photograph from a setting in rural PNG. It's like many parts of the rural Pacific Islands. Our staff here and to the right are going out conducting outreach work in the same environment. Is this what we want to do? Is this what we need to do to achieve the high coverage that we need to truly embark down the path towards elimination? We started recently to explore this in much more detail and think about what would we need to do to move towards elimination in Papua New Guinea. And we're planning to start a proof of concept program involving all women and girls aged 9 to 14 in Western Highlands province in Papua New Guinea. We plan a model that's based from the provincial hub that we've already established, and with rural outreach and community outreach in order to provide vaccination at high coverage and screening at high coverage so that we can reach the rural majority. Now, in addition, another very, very key population at increased risk that must not be left behind as the elimination agenda advances are those women living with HIV. And those women have, of course, a higher risk of invasive disease than women who are not living with HIV, probably 4 to 5 times higher, perhaps greater. And we've been looking at how we can augment the current strategy that we're using, the HPV point of care test and treat, and to see whether it's of value to add an additional step. One concern has been that we may find that some women with early invasive disease are not adequately managed by thermal ablation. And so perhaps the hypothesis is perhaps we need to have an additional screening, additional visualization step using something like, as you see on this slide, a digital colposcope, which are highly mobile, battery operated, relatively easy to use compared to traditional colposcopy, and far less expensive. And so we've been looking at this in PNG and also earlier in Myanmar to see, is this an additional strategy that would be of value? And in particular, could this assist us to ensure we can provide equally robust and accurate and high performance screening among women living with HIV? Very recently, at another virtual conference, I was involved in the Preventing Cervical Cancer in Indo-Pacific conference. We were able to announce this new program, the Eliminate Cervical Cancer in the Western Pacific project, which will be starting very soon and will include women in all of Vanuatu and girls aged 9 to 14, the whole of Vanuatu, and the same populations of 9 to 14-year-old girls and all women aged 30 to 54 in Western Highlands Province, Papua New Guinea. So in total, over 120,000 girls and women will be engaged in this program in the coming years. And this is a proof of concept approach that will show us, can we achieve those WHO targets? 90% of girls aged 9 to 14 vaccinated, 70% of women aged 30 to 54 screened by the age of 35 and again by the age of 45, and 90% of all those who are found to be HPV positive and to have underlying pre-cancer or cancer are appropriately managed. So they're managed either by thermal ablation, a point of care, or they're managed by appropriate referral and then ongoing specialist treatment, be that surgery or referral to palliative care services. At the same time, at the same conference, we were also delighted to see that the WHO were able to join us and present the updated cervical screening guidelines, which I understand will be formally launched in the coming weeks. And these guidelines, for the first time, really have endorsed all the key elements that I've been talking about today. So both the self-collection, the vaginal self-collection for testing, the point of care HPV testing, and also thermal ablation, building on their earlier recommendations and reports, endorsing thermal ablation actually above cryotherapy as the treatment of choice for pre-cancer. So in summary, In the past 10 years, we've evaluated and found an innovative, effective, acceptable, cost-effective, and we believe scalable screening model. And we've established this in PNG. It's a program now we're wanting to expand under this new initiative to Western Highlands and also into Vanuatu. But it's also an initiative that we're separately in discussion with our key partners in PNG to endorse and roll out nationally. And I'd just like to finish by recognizing all of those that contributed their time and their expertise to supporting me and my team. And of course, to especially thank the women and the families and the communities for their participation, their co-design, their input from those women and their families and the communities have been essential to our work and will remain essential into the future. And in particular, those women who are most at risk and most vulnerable, including not only the rural majority, but of course, women living with HIV and Papua New Guinea and other settings in the Pacific who remain at increased risk and for whom we need to ensure the most effective and robust and acceptable algorithms can be implemented. Thank you.